So next, we're going to move from the brain to the gut and speak about something else that's very meaningful to parents, which is GI issues. That is something that is so commonly talked about in our parents group, from reflux to feeding tubes. So I am so happy to introduce you to Dr. Ihekweazu. She's an assistant professor of pediatric gastroenterology at Texas Children's Hospital and Baylor College of Medicine in Houston. She is at the Bluebird Rett Clinic, and she came here today to give us digestible tips about GI and FOXG1 syndrome. And again, we'll take all the questions after with all three presenters. Thank you. Okay.
Well, while they're pulling up my slides, I'll just say hello and a special thank you to Nicole, Angie, Nasha, the whole team. The work that you all are doing is incredible, inspirational. I've just been wowed this entire conference. So I am both honored to be here and have the chance to talk to you all today, and to have the opportunity to take care of children like yours in my clinic. So my goal today will be to be pretty practical and talk about things that you all are probably very familiar with, and hopefully there'll be some good take-home points that you can take home with you. I have no disclosures that are relevant to the talk I'm going to give today. So our goal will be to review nutritional and GI problems that we see in patients with FOXG1 syndrome, and to discuss some strategies for kind of helping those problems. I'm going to start with a couple of definitions just so that we're all on the same page. So you probably have heard of BMI, or body mass index. This is kind of the gold standard for what we use in nutrition to indicate someone's nutritional status. And it's basically a ratio of someone's weight to their height, so sort of how big they are for how tall they are. Normal is anywhere between the 25th and 75th percentile. We start to get a bit worried when someone is outside of that normal range, specifically kind of at the bottom of the curve, less than that 5th percentile, or conversely, at the very top of the curve, above the 85th percentile. Something that we have really leaned into is something called the suprailiac skin fold thickness, and this is a little take-home point that I want you all to remember. So you see these little calipers. Obviously, you don't have that at home, but what works really well as calipers is our fingers. So during COVID-19, when we were doing a lot of telemedicine visits and weren't able to bring patients into the clinic to really evaluate their nutritional status, we taught all of our families how to do this at home. And the goal here, if you take your little fingers, everyone kind of deposits fat differently in our bodies, but that little area kind of right there, the suprailiac skin fold, tends to be not a place that someone is particularly prone to deposit fat or not deposit fat, so we can use that as a good marker of general nutritional status. If you do that little skin pinch, we want it to be about the size of your finger, your index finger. If it is much more than that, you're grabbing a big chunk of fat, maybe we need to go on a diet. If you're having a difficult time kind of picking up fat and all you're getting is skin, that can be a sign of nutritional issues and malnutrition. And so something that we use kind of as a marker, I do it on every patient that I see in the clinic, and I discuss it with the family so that between visits, if you're worried someone's losing weight, you're worried someone's gaining too much weight, you can kind of do that as a marker for yourself. Generally, if a patient is in that BMI range less than the 5th percentile, and we are really struggling to get them back into a normal place on that BMI curve, that's when we start talking about alternative feeding methods. So that can include oral supplements, that can include nasogastric and gastrostomy feeding. And similarly, like I mentioned, if our BMI is greater than the 85th percentile, we want to protect our children from all the things that come with obesity and being overweight, diabetes, high blood pressure, and all the things that we as adults have to deal with. And so we will talk about kind of dietary energy reduction in that situation. Patterns of growth can vary in FOXG1. There are a number of patients, about 50% are going to be normal height, I said normal height or short stature there, but normal height, with short stature being about 50% as well. We can have anywhere from normal, poor, or excessive weight gain. In FOXG1, about 35% of patients will have difficulty with gaining weight. When we have patients who are low in weight or high in weight, but specifically high in weight, we do want to look at how much of their body is muscle mass versus body fat. Muscle weighs more than fat, so our children who do not have a lot of muscle mass, if their weight is increasing, that could be a sign of extra fat deposition, which is not something we necessarily want, so we can sometimes allow those patients to be a little bit lower on the growth curve than a neurotypical child and still be comfortable with that, just because they don't have as much of that muscle mass weighing them down. When we see a patient who is not gaining weight well, we have to think about a couple of different things. Is this because of inadequate dietary intake? Is there a genetic downsizing, which happens to kind of many of us as we reach puberty? Is the patient having a lot of seizures and it's burning extra calories? There's a lot of things that we kind of take into account. But some of the things that we see quite commonly in FOXG1 is issues with poor chewing and swallowing skills. And then additional things like really bad reflux, really bad constipation. Those can affect how well our children are able to take in nutrition. And like I mentioned, seizures can certainly impact that as well. So let's talk a little bit about the chewing and swallowing problems that we see. So up to 90% of patients with FOXG1 will have issues with difficulty feeding. That can be issues ranging from poor chewing skills, difficulty with using the tongue to lateralize food and make food bolus, forming the food bolus in the mouth properly, lots of pooling of liquids in the back of the throat, drooling of liquids out of the front of the mouth. And then there are things that are a little bit more serious, like laryngeal penetration of thin liquids and even aspiration of liquids that can put patients at risk for things like pneumonia. That is where occupational therapy or speech therapy, feeding therapy becomes very important for our children. Generally, if a patient is really struggling to gain weight, or they have significant weight loss over the course of about 6 months, with that BMI staying below the 5th percentile, or we see the weight gain just sort of stops and the curve flattens, that is when we start to really think about alternative feeding methods like a gastrostomy tube. Certainly, if a patient has aspiration pneumonia, so I mentioned if patients are struggling with aspiration, it puts them at risk for pneumonia. Once we see that happen, then the conversation of gastrostomy tube also becomes very relevant. And then there are times when you as parents recognize that this is just not working, and that's actually really important as well. Patients can sometimes start refusing to feed, not being interested in eating. Meal times can take upwards of an hour to get enough food for the patient to grow. And then medication administration. Maybe your child is willing to eat, but getting those seizure meds in become a real struggle. And that also can be a really clear indication for a gastrostomy tube, or at least having that conversation. About 35% of patients in the literature do require a feeding tube at some point. So this is a very relevant discussion and one that we frequently have to have. Let's talk about reflux. So up to 90% of patients with FOXG1 syndrome will have issues with reflux. So what is reflux? It is literally food from the stomach or liquids from the stomach coming back up into the esophagus, the opposite direction it's supposed to go. This can happen for a number of reasons, but generally we think about kind of poor motility of the esophagus or stomach. So if food's not exiting the stomach an appropriate amount of time, that can increase the risk for reflux. We all have a little sphincter at the bottom of our esophagus, and its whole job is to close and keep food in the stomach, but sometimes that sphincter doesn't work very well, and so it allows food and liquids to kind of slosh back and forth. In our patients, we can see a variety of things that can be a sign of reflux. So irritability, like Dr. Benke mentioned, nighttime awakening, inability to fall asleep, vomiting. People tell me they just hear it, like the kids burp and you hear that wet burp. Regurgitation, where you actually see the food come out. Sometimes it just dribbles out of their mouth, sometimes a little bit more forceful. Sometimes when children are having a lot of reflux, they just don't want to eat because it doesn't feel good, and so they start to refuse to eat. And then certainly we can see coughing and even wheezing, especially if it ends up leading to like an aspiration type event. There are some tests that can be used for reflux. I will qualify these tests that are listed. Upper GI series, if your child has ever had one, it can show reflux. It's not a good test for reflux because it is a moment in time. So if we see reflux on an upper GI, that means your child had reflux at that moment. If we don't, 5 minutes later they may have, but we just didn't capture it on the study. So it's not a great study to look for reflux, but we certainly can see reflux. There is a test called a pH probe where we put a little probe down the nose. It goes down the esophagus, can actually measure over the course of 8, 12, or even 24 hours how many episodes of reflux are happening. And like I mentioned, with delayed emptying of the stomach, often children are at increased risk for reflux. And so there's a gastric emptying scan we can do to look for that. So what do we do if a child is having reflux or we think that reflux is contributing to some of their symptoms? Well, there's certainly diet changes that we can make. Decreasing spicy food, caffeine, chocolate, tomatoes, and citrus fruits, all of those have a lot of acid in them and can worsen reflux and the symptoms from reflux. Positioning, trying to keep the children upright for about 30 minutes after eating, elevating the head of the bed when possible. And then certainly medications are our best friend with reflux. So acid blockers like antacids, H2 receptor blockers, that's something like famotidine, and then proton pump inhibitors like Nexium you may have heard of. Prokinetics come into, that's just a fancy word for moving things forward. And so we sometimes will use medicines that can help move things out of the stomach faster if we feel like gastroparesis or delayed emptying of the stomach is contributing to reflux. And then kind of on the far end of the spectrum is surgery, so a fundoplication that kind of helps tighten that lower esophageal sphincter area when the lower esophageal sphincter is not working well. There are pluses and minuses to fundoplications, and so that is not something that we jump to, but it is a discussion that we will sometimes have with our surgeons. All right, the big one, constipation. I am sure many of you, if not all of you, at some point have dealt with this with your children. So constipation definition is pretty broad, just difficulty with pooping. There's lots of different causes for constipation. The most common is what's called functional constipation, and that is basically a catch-all term for we don't have another thing to point at, but you're constipated. There are some true neurologic conditions like Hirschsprung's disease that can lead to constipation. There are some endocrinologic problems like really low thyroid function, and then certain drugs that can also increase the risk. We think about constipation in children who have less than 2 bowel movements a week, poops that are hard, blood with wiping, children who really strain and work very hard to get poop out. We often see abdominal distension, lots of gassiness, abdominal pain. Constipation can be incredibly painful, often to a degree that people don't recognize how painful constipation can be. We have many neurotypical children who end up in the emergency room. Everyone's sure they have appendicitis, and it turns out they have a colon full of poop. It can be incredibly painful. Flatus, which is just passing a lot of gas, all that poop causes lots of gas production. Urinary tract infection, so the most common cause of urinary tract infection, recurrent urinary tract infection in children is constipation, and so that is something that often goes hand in hand. Also, if your belly is full of poop, you don't want to eat, so feeding refusal, vomiting, and even increased seizures due to the discomfort from the constipation. How do we test for constipation? Rectal exams. I don't do rectal exams that often, to be honest, because it's just not fun for the children, and I often don't need it, but it can be informative. Abdominal x-rays are a really easy way for us to see if there's a lot of poop in there. And then a barium enema, that is a special type of x-ray where you give an enema through the rectum, and that can help us kind of define if there's something a little bit more serious going on, a neurologic issue, for example. So how do we treat it? There are certainly dietary changes, increasing fruits and vegetables, trying to find high-fiber cereals that we can introduce, sorbitol-containing fruits, so that's why you hear about things like prunes for constipation, so that can actually help loosen things up a little bit. And then some patients will have some success with probiotics. Physical activity is really helpful. For our children who are non-mobile, physical therapy can be a great way to help them get physically active and help things move around. And then we get to medications, which are really incredibly important for our children with constipation. We like to think of them in sort of 3 different groups, the mushers, the pushers, and the pullers. So the mushers, the ones that make things soft, are things like Miralax, which is that polyethylene glycol, lactulose, mineral oil, milk of magnesia. We use this very, very commonly. Pushers are the ones that are called stimulant laxatives. They actually help squeeze the colon to help push the poop out a little bit easier, and that's things like bisacodyl and senna. And then the pullers, the ones that we use from below, so glycerin suppositories, bisacodyl suppositories, docusate suppositories. And finally, we do sometimes need to do an actual full disimpaction or bowel clean out, and often we will use enemas. Sometimes we have to do lavages from the top to actually fully clean out a patient. For patients who have very, very refractory, very, very severe constipation, there are some surgical options. These are not frequently needed, thankfully, but there are some surgical options for those who really, really struggle. And often I will point out that we use a combination of these medicines. So if I hear a patient tell me they're on Miralax, the poop is soft, but it's just not coming out, maybe that means we need to add a stimulant, a pusher, to kind of go along with that Miralax to help both push and soften. Similarly, sometimes a little stimulation from below is all a patient needs, and so we do kind of a combination of things in order to kind of get the right combination for that patient. Gas bloating, very common, also, again, very common in the setting of constipation. That is whenever you end up with gas trapping in the stomach and the intestines. Often we see this when parents tell us that their child gets more and more distended throughout the day. It can be from air swallowing, it can be from constipation, it can be from bacterial overgrowth, which can happen in the setting of constipation, but also can happen separate from constipation. We often see burping, passing gas, abdominal distension. In the setting of bacterial overgrowth, you can actually see diarrhea that goes along with this really bloated, gas distended belly. X-rays are a very easy way to see that there is a lot of gas in there. If a patient is consistently having issues with abdominal distension and gassiness, we do often want to rule out celiac disease, which is a gluten allergy, as a contributing factor. If there is a potential exposure, making sure there's no ovas and like parasites like Giardia. If kids have been swimming in a lake or been exposed, been on a trip overseas, or sometimes you can see that kind of over a long period of time sneak up and cause problems. Lactulose breath test is something that in neurotypical children we can use. It's really difficult to do in FOXG1 patients, and so we don't often use that. And I'll be honest, I don't often use it anyways, but it is an option, so I just mentioned it. So what do we do about lots of bloating and gassiness? So trying almost the opposite of the constipation, you kind of want to avoid some of these complex sugars that are in fruits and things like that, especially juices. You kind of want to avoid those juices. We all know that beans can increase gassiness, so avoiding legumes and beans, lentils, things like that. Some patients are really sensitive to dairy and lactose, and so trying to either avoid dairy or introduce a lactase enzyme to see if that is potentially helpful. And then, of course, if there's a gluten intolerance or celiac disease, we definitely want to avoid gluten. And then the number one medicine for gas issues is Gas-X or simethicone. Works very, very well to go in there and pop those gas bubbles. We can sometimes use antibiotics if we're worried about like a small bowel bacterial overgrowth situation. Probiotics can be helpful, and certainly laxatives if constipation is an issue. I will mention biliary tract disease. It is not very clear how common this is an issue in FOXG1. We know in our Rett syndrome patients, about 5 to 7% of them will have biliary tract issues, and I like to mention it just because it's something that can be sort of hidden and difficult to find if we're not thinking about it. So basically, this is anything that affects the gallbladder and the biliary tree. Belly pain, nausea, vomiting, loss of appetite, fever, those can all be signs, which also obviously bleed into signs of many other things. We can pretty easily diagnose this with an ultrasound. There are some more sophisticated and fancy tests that we may need to do if we see abnormalities on an ultrasound, and there are some medicines and sometimes surgery that's required to treat them. So I just mention it as something to always keep in the back of our heads if there's lots of abdominal pain and we don't have a good reason for it. And similarly, low bone mass is also an issue that we see a lot in our Rett syndrome patients. There are increased risks for fractures as they get older, and it is not yet well documented whether this is an issue for FOXG1. So I bring it up as something for us to think about, and it's something that we really think about in our clinic when we see the FOXG1 patients. So basically, the risk factors are increased when there is not enough calcium and vitamin D in our diet. So decreased milk intake, not enough dairy intake can potentially put you at risk for not having enough of that vitamin D and calcium. Anticonvulsants, similarly, immobility puts you at increased risk for low bone mass and potentially fractures. Things that we can do if we are concerned about this is something called a DEXA scan or an X-ray, a certain type of X-ray that we can do. And ultimately, ensuring that the diet is replete in calcium and vitamin D is incredibly important. And so here I won't go through this in detail. I'm just listing there are some amounts of calcium that we make sure that our children are having at different times in life. It increases up to about 18 and then stabilizes out. Generally, if you get a few good servings of milk or yogurt a day, you're in a good place. And there are some calcium supplements that you can buy. Vitamin D also is incredibly important. The easiest way to get vitamin D is the sun, but that's not always easy to access depending on where you live and the time of year. So often we do need vitamin D supplements for our patients. So in summary, nutritional and GI problems are very common in FOXG1. Our goal is to be proactive in the diagnosis and treatment in order to maintain quality of life for these children and adults. And any symptom that causes you as a parent or caregiver to be concerned should really be evaluated by a physician. And with that, I think we might actually be at questions.